Hi everyone, I think we'll make a start. There's quite a few of you logged on now, so I hope you can all hear me okay. Now you have got an option to ask questions, but you have to type them in, but I can't see the questions until I finish the webinar at the end. So any questions, type them in either at the end or as we go along, and then when we get to the end of the webinar, I'll have a read through and answer what I can. So firstly, I haven't got a proper funky microphone plugged into this laptop, so unfortunately, because I live next to a farm, you will be hearing some of the road noise outside, but I'll speak up, so hopefully I won't get any loud tractors or anything going past. The other thing is as well, I'm 8 months pregnant, so if I start getting out of breath, it's not because I'm doing exercises while I'm doing this presentation, it's because when I talk, I get out of breath. So, but anyway, hopefully this will all go okay. As I say, if there's any issues, just, oh, no one's put anything in yet, so I'm guessing you can all hear me okay. It's always really weird doing webinars because I'm literally sat here looking at a wall, so I can't see the responses from you all. Okay, right, so today we are going to look at casting. So we'll look at all the different techniques, or the main ones that are out there. So we'll talk about Plaster of Paris, right through to scanning technology, which is becoming a lot more popular now. But the main emphasis of this presentation is to take some tips away and make you think about how you're doing your casting at the moment, and to think about how you're doing it and getting a good impression of the foot, basically, or if you're new to it, some of the things that you possibly need to be thinking about. Okay, so our objectives for today are to look at the purpose of casting, so why we do it. So I say casting or taking a foot impression, but yeah, I mean sort of one and the same thing when I say that. We're going to talk about communication because, I mean, that's the answer to the first point, really. That is why you're taking a foot impression, because you want to communicate the information about that foot back to the lab. So the whole purpose of it is a form of communication. And I think really if you take that on board with every step of your casting method, now whether you like computers, do you like scanning, or whether you like Plaster of Paris or foam impression box, or whatever method you prefer, every step of the way and every part of that casting process or scanning process, you need to be thinking about what you want to communicate and what's the best way of doing this. And also remember, you almost can't send us too much information, so it's not a case of taking a quick cast and sending it off. It's making sure that cast encompasses all of the information that you need to give us as a lab, or to give whatever chosen lab you're using. So within that, you want to be thinking about background information, measurements, reference points, and as I say, we'll come on to that in more detail as we go through the presentation. We'll obviously look at different casting methods. People tend to have their preferred way for various different reasons, or if you're new to it, maybe you're still exploring that. And we'll also look at the pros and cons involved as well. So the fors and against, the advantages, the disadvantages, and so on and so forth for each different type of method. So why do we cast? Is to create a mould of the foot from which a functional foot orthosis can be fabricated. Now I put functional foot orthosis there, or maybe it's a TCI, or that depends on your patient group. But essentially it's to make a mould of that patient's foot from which a casted prescription orthosis can be made. So essentially it's to capture foot data. So we need to get as much information as we possibly can within that cast to then forward it onto the lab. Now communication is very, very important, and it doesn't really matter so much what technique you use, as long as you get that communication across. And certainly, I've said on webinars before, I've been qualified since 2003. I've worked with some very experienced biomechanics podiatrists, and they don't all agree on casting techniques, and some of them will be very adamant about one method over another, but they get the results that they want, and it works for them. And I think, as in a lot of things with working with patients and clinicians and so on and so forth, if it works for you and there's a reasonable amount of evidence to back it up, then that's your sort of justification for doing it. Now, one thing I want you to think about, and until I worked with a commercial lab, I never really thought about this too much. I mean, I presume my casts were always okay because I always got back what I wanted pretty much, but I never sort of thought too much about where my cast was going. So essentially what you're doing is you are asking a lab technician who you've never met. So this isn't a fellow podiatrist, this isn't someone who's necessarily been qualified for 30 odd years and seen hundreds of patients. You're asking a lab technician who you've never met to make an exact custom device for the foot of a patient who they've never seen. So when you think about it like that, it's sort of a case of, oh my word, how many points along this process can it go wrong? So and also, if you're just taking a cast and sending a prescription, most of the time you're not even talking to that person who's making that bespoke device for your patient either. So I hope that sort of emphasises how important communication is. Okay, so they're basically the four common casting methods. Didn't really say much, you haven't missed much there. What does the evidence say? So essentially what I just said is that I'm not going to give you a definitive black and white list of how exactly you should take your cast and what you should and shouldn't do. And I think any list or any lab which tells you exactly how to do it with no sort of grey area, I would be slightly cautious of, only because all your patients are different. And it all comes down to the bottom point down there. It depends what you want, what your patients come in with and what you're trying to achieve. And that's not necessarily ever the same for two patients alike. So it all comes down to what you want. So what the idea of this webinar is to talk around the subject, look at the evidence, and then give you some ideas to sort of think about and take away and digest and hopefully improve your practice as well, or certainly reflect on your practice. So as I said, there isn't unfortunately a huge amount of evidence looking at different casting techniques and comparing them and seeing how effective they are. And you'll see that by my sparse reference list, or not so sparse reference list at the bottom at the end of the webinar. But what evidence there is out there suggests that non-weight bearing is more accurate. Now, I'd certainly tend to agree with that more, but that's just my own personal opinion. I've worked with other colleagues who are very, very clever and who prefer semi-weight bearing, and they get very good results. So as I said, it all comes down to what you want to achieve and what your patients come in with and what you're trying to do. So we'll have a little look. Here's a couple of papers I found. So this piece of research here back in 2002, it's a comparison of 4 methods of obtaining a negative impression of the foot. So the 4 methods that they looked at were non-weight bearing plaster of Paris casting, partial or semi-weight bearing with foam impression boxes, and then partial weight bearing with a laser scanner, and non-weight bearing with a laser scanner. So there was 2 different ways of non-weight bearing and 2 different ways of semi-weight bearing there. And the idea of the study was that it compared the reliability and the accuracy of these 4 methods. And they used measures. They looked at rear foot and forefoot width, forefoot to rear foot relationship, arch height, and they also looked at, I think it was rear foot and forefoot width and forefoot to rear foot relationship, that was measured clinically for each subject as well. So it's quite an in-depth study, but essentially what they found, and this is taken straight from the abstract, is that foot measures are significantly influenced by the method used to obtain a negative foot impression. The methods differ in reliability, and what they said in the end was that plaster casting may be preferable to the other 3 methods when it is important to capture the forefoot to rear foot relationships, as in fabricating a functional foot orthosis. So what they've set out, the 4 methods there, scanning, weight bearing and non-weight bearing, semi-weight bearing, foot impression boxes, or non-weight bearing plaster of Paris, they found that for all the things they looked at, plaster of Paris non-weight bearing method was the most reliable. But as I say, that's just one paper, but that's what they found. And then another study there by McPoyle. So the purpose of this study was to compare, I think they looked at forefoot to rear foot angles, and it was a comparison of 3 methods used to obtain a neutral plaster foot impression. So the 3 methods I've highlighted there in red were supine non-weight bearing, prone non-weight bearing, and sitting semi-weight bearing. But they found that the non-weight bearing was significantly different from the sitting semi-weight bearing. So, and again, they found that the non-weight bearing tended to be more preferable to semi-weight bearing. So what they found in this study is it didn't seem to make a lot of difference whether your patient was laid supine or prone, but it did make a difference whether they were semi-weight bearing or not. And what they said was the results indicate that the same forefoot to hindfoot alignment can be obtained using either the supine non-weight bearing or prone non-weight bearing method, but not with the sitting a semi-weight bearing method. Okay, so the two studies there pretty much support each other, that non-weight bearing tends to be more preferable. But again, we're looking at fully functional foot orthoses there. We're not looking at things like total contact insoles, or maybe patients who have got less range of motion, or other stuff that you might be prescribing for. So again, think to what your patients are coming in with and the sort of patients you're seeing and what you're trying to achieve here. So the key message, I think, in all of this, which is why I've highlighted it nice and bold there, is that you must understand the principles of taking a good cast and getting a good 3D impression. So it's not just a case if you've got a scanner of aiming it and firing, or getting a foam impression box and plonking your foot in and sending it off. It's very important to understand what you're trying to achieve, what to look for once you've taken your cast, and getting every bit of communication possible into that cast in your prescription form. So we said the list before, so I'll start with Plaster of Paris. So this is sort of the one that's been around for decades, good old tried and tested method. Pictures there just show the patient laying on their tummy or laying prone. You can see from the bottom picture there, it can be a bit of a messy process. So pros and cons. Pros are if you do it properly, and it is tricky to master. If you do it properly, you do generally tend to get good results. It's easy to manipulate the foot. So once you've got the Plaster of Paris wrapped on, you can manipulate the foot into whatever position you choose to put it in. That's easy enough to do. It's tried and tested, so there might not be that much good, might not be tons and tons of research papers out there, but I mean, podiatrists have been using this method for decades. And orthoses have been made and patients have been getting better, so we know it works. It can capture an uncompensated foot position. It also captures everything because the Plaster of Paris comes up the side of the foot, so you get all the curves and lumps and bumps and anatomical lesions on the side of the foot. And it's easy to mark lesions on there as well, so whether you choose to put lipstick on the bottom of the patient's foot, or marker pen or biro, or whatever you have to hand, that transfers quite nicely and quite easily onto the wet plaster. Disadvantages: patients will tend to think it's archaic, and I think we've all been there. Well, I certainly have in private practice, where I've got my Plaster of Paris out and they just sort of look at you like, what on earth are you doing? When I went to the running shop round the corner, I trod on a treadmill, and that was far more accurate, and just because something's lit up and gone ping and been connected to a computer. So you have to sort of get through that, unfortunately, with some patients. They think it's old-fashioned and that you're not sort of up together with the times. It can be messy. I guess that depends on you and what you're like at taking casts. I've certainly worked with podiatrists in the past that managed to get it all over the ceiling, all over themselves, all over the patients, and trodden halfway up the corridor. But I think with practice you can get the messiness down. One thing you can't avoid is it is time consuming. Whatever you do is going to take a certain amount of time for that plaster to go off. And there have been studies looking at cost benefit analyses. I think one of them came out of the La Trobe University in Australia, and found that digital scanning was far more beneficial from a cost benefit perspective, because it just took less material, it took less time, and if you factor all that into it as well. So perhaps if you're an NHS account, you're looking at a good sort of 20-30 minutes appointment time to do a Plaster of Paris, and other methods are a lot quicker. But again, it depends what's important to you in your practice. They are fragile and they can crack. Again, I remember a case years ago working for the NHS where a box of 20 casts were sent off, and the postman dropped them, crushed them, ran them over, or did something. And then we had to get all the patients back and recast them again. And then I definitely have to agree with this one, as children. If you've ever tried to cast a hypermobile child with ADHD under the age of about 7 with Plaster of Paris and expect them to sit still for 15 minutes, it's a nigh on impossibility. So yeah, either good luck with that one or try a different method. Now, there's different methods of taking a Plaster of Paris cast, and I've listed some of them there. So I do have a preferred method, but again, based on what I was taught and what works for me, not necessarily because it's the best or it's the most accurate or the research says it's the best. But you've got a neutral position where you hold the foot in a neutral position, and I've got a slide, I'll talk a bit more about that in a second. Pronated position, so again, there's different opinions on this. Why do you want your foot in neutral? Why would you not want it pronated or semi-pronated? Lots of different arguments for that, but generally speaking, I think if you're casting the foot in a pronated or semi-pronated position, it's probably because you can't get the foot into a neutral position, or perhaps you want it in that setting or that position because you're doing something like a total contact insole. And then you've got two different techniques: suspension technique or direct pressure. So suspension technique can be done either with the patient lying on their front or their back, so supine or prone. And then the prone is referred to more as a modified suspension, where you use the joints are drawn down from the sulcus. So my preferred method is suspension technique with the patient laying prone. And there's two reasons for that. One is that I get in a right old mess if I have the patient laying on their back. I think, and people have said the other way around, they said they can only do it with the patient sitting up, they can't do it with the patient laying on the front. But I also think if the patient's laying on their tummy or they're laying prone, then they tend to relax more. They're not extending tibant, they're not trying to help you, they're not trying to hold the foot in a certain position. They're more likely to relax and let you get on with the job and manipulate the foot into the position that you want it to. When I have tried doing it supine, the patient kind of talks and tries to help and tries to hold the foot, and then you get sort of different muscle contractions and so on because they're sort of trying to help. So it doesn't always happen, and as I said, that's just my preference. And then also with suspension technique, you tend to get a better evaluation of the forefoot to rear foot position. But you must remember to dorsiflex the ankle to stop an equinus when you're doing it. So if you're putting it in neutral position, remember to dorsiflex the ankle as well. And then direct pressure, again, you can do it with the patient prone or supine, but with this one, you're pressing on the metatarsal heads. So again, different thought processes with this. The only thing I would say is it then creates a dent underneath the fourth and fifth metatarsals where you're holding it, and you could argue that that's making a change on the sort of the osseous formation of the foot, and you're technically loading it. But as I say, I know lots of clinicians that use all those different methods for various different reasons, and they get very good results. So to a certain extent, it is what works for you, as long as you understand the differences and why you're doing what you're doing. So at the end of the day, what are you trying to achieve? And don't forget the patient. So at the end of the day, it just always comes back to the patient and what you're trying to make for that particular patient and what their needs are, what their diagnosis is, and what you need for their management. Right, slipper socks. Okie dokie. So slipper socks is a polyester resin impregnated material. It's not as messy as Plaster of Paris, so this is the advantages. It is a lot quicker because it goes off quicker. You don't need things like a plaster sink or aprons or lots of apparatus around you to keep the room clean. They're easy to store, they're less fragile, so if you drop them, they don't tend to crack and break. And also, if you wanted to, you could do a dorsal impression of the foot as well. So we don't tend to do that as podiatrists, but say orthotists and other health professionals may want to do that. Or you can come further up the ankle if you're making something like an ankle foot orthosis. So you've got sort of more versatility from that point of view. Now, I say not as messy, but you must remember to use gloves. And in the past, I have forgotten to put gloves on, and this stuff does not come off your hands with anything. And I mean, nail polish remover, white spirit, you name it, it just doesn't come off. So when I did do this without gloves once, it took about 2 weeks for the resin to slowly peel off my hands. And I think for that reason, I've never used it again since. It's also a bit more expensive, but then that depends. If you look at the cost time or time analysis in that, then you're saving time on it. So does that come into the cost? But generally speaking, a roll of plaster is cheaper than a slipper sock. You have to think about how the lab uses them, but also as the resin cures, it can retract. So what the LBG lab have certainly found is that with some clinicians who use slipper socks, especially if they're casting in a supine position, is that the resin can contract ever so slightly, which then has an effect on the medial lateral arch. So it's not all the time, but it's just something to be aware of if you like using slipper socks. So, but certainly the people that I know that use them absolutely love them. So, right, 3D scanners. So these are becoming ever more popular, and the technology is getting better all the time. So pros is they're very quick, they're modern, so patients like them because they light up and they go ping and they think they're getting the latest technology and so on and so forth. There's no mess with them, there's no postage because you literally take the scan and you email it, so you haven't got to mess about going to the post office or stuff getting lost. It's easy to do repeat orders, so you haven't got to get your patient back in and recast them because you've got all that data saved already on your computer. And also you can manipulate the data as well, so there's various systems out there now where you can take the cast and then you can have the cast up on your screen and you can add bits on and take bits off and manipulate that information and make the changes yourself and then send it off to the lab. So there's that sort of technology is developing all the time. Also the lab can manipulate data as well, so sort of the possibilities with this certainly going into the future are almost endless, I suppose. So the cons or the drawbacks is make sure it is actually a 3D scanner, not a 2D scanner. There's plenty of marketing out there for scanners which are almost like glorified photocopiers really, and they're only taking a 2-dimensional scan and not a 3D. So again, that's a whole different talk on its own, but you cannot get a 3D impression accurately from a 2D scan, so do be careful not to get caught into that one. Another con is that it still needs to be taken accurately and you still need to take the due amount of care that you would if you were doing something like a plaster of Paris. And I think the risk here is because it's so quick and easy, there is that temptation to quickly aim at the foot and fire and not think about the position that the foot's in or the resultant cast that you've taken. It can be weak at positioning the foot in space. With plaster of Paris, you've kind of got more reference points. With the foam impression box, you've got the ground as a reference point, but with 3D scanners, it's not quite as good as that. And you do sometimes need to adjust your script accordingly. So just because it's quicker and it's essentially easier, doesn't mean that you don't have to take the same care when taking these scans. So as I said, it's becoming far more popular. Technology is increasing all the time, and I think probably if we jump forwards to another 10 years, and this is probably going to be the preferred method. At the moment, the most popular methods are plaster of Paris and foam impression boxes, but over the last sort of 4 or 5 years or so, scanners have become a lot more popular, and I think they will probably end up sort of overtaking it. So if you think about using a scanner, which scanner? I'm not going to tell you which scanner, A, because I'm probably the most IT unsavvy person in the world, and I like plaster of Paris, but also it's got to be what works for you. So essentially there's certain things you need to look for if you're going to be using a scanner, and that is, does it capture everything? So it's easy to get caught up in sort of the marketing or the sales rep showing you how wonderful it is and the lines you can draw on and how great it looks to the patient. But does it capture everything that you need it to convey that communication that you need to give to the lab? And one of the things to consider here is whether it's laser light or white light. So in a nutshell, laser light kind of bends around corners, so you get all the curves and lumps and bumps in, it's not guessing it, whereas white light doesn't. So if you're coming up like the side, or you want the back of the heel or the posterior heel curve or your malleoli, your laser light devices will capture that better. Another important point on there is you should never choose something that's going to limit what you want to prescribe. So if you've been using plaster of Paris for years and you're able to achieve everything or communicate everything through that, you shouldn't give up one of those things just because you want to start using a scanner. So it should do everything that you're able to do now, plus a little bit more if you're going to change. And then also make sure you've got the good support and backup service. I suppose it's a bit like buying a laptop from a, I don't know, car boot sale, and then it crashes and goes wrong if you've got no setup or backup with that. So yeah, make sure you've got the support from the manufacturer or the provider should you have any problems with it. So now I've got a couple of slides here on the structure sensor because this is becoming really, really popular because it's much cheaper. So scanners in the past have been sort of several £1000s, and they're quite an investment, which work well if you've got a busy private practice, but this is quite an outlay to start with. The structure sensor, which clips onto your iPad, is a lot cheaper, as they're about £230. Most people have got an iPad anyway, so this is becoming really, really popular. I've put a link on there if you want to watch a video on how to use it, or indeed, if you, I should have said this earlier actually, to watch a video on any of the casting methods. If you go onto the LBG Medical website so www.lbgmedical.com/videos, and then if you click casting, it's got the different casting methods on there and it will take you through it. But there's an example, and this isn't uncommon, of a cast that we've had sent in sort of a few months ago. So you can see as a lab, they do get a few issues with some of the scans which are sent in. I'm not quite sure what's happened to this. There's obviously quite a lot of artifact in there. But even if you took the straight line going across, I think is probably the plinth that they're laying on. But even if you took all that away, you can see sort of underneath the heel area here and into the arch, there's all sorts of lumps and bumps and indents. And I think if you had a Plaster of Paris cast that looked like that, you probably wouldn't send it in. So I suppose the argument there is, where would you send that in? Why would you send that one in? So never just assume something's quick and easy. The structure sensor is certainly sort of marketed and made to look quick and easy. But it's still important that you take a really good scan which has all the information in, and clearly that's not been the case with this one here. So if you are using a structure sensor, or you're thinking of buying one, or you've just bought one, these are just a few things to consider. So ideally, it requires 2 people. Now, if I was working in a full-time busy private practice, I think I probably would swap to the structure sensor, just because it is quicker, it does look better. There are all sorts of things you can do with it. I do quite like it. But if it was me, I think I'd be training my receptionist to take the scan while I manipulated the foot. Because if you think about, if you're used to using Plaster of Paris, you hold the foot in a certain position, you hold the sulcus, or you load it, or whatever you do. Maybe you push the first ray down, maybe you dorsiflex the hallux, maybe you take out a supinatus. There's all sorts of things you might be doing when you're manipulating that cast. With a structure sensor, if you're just leaving the foot to hang there, again, it'd be non-weight bearing, which we know is preferable, but you can't manipulate the foot and take the scan at the same time. And there are things like positioning frames and sulcus sticks, etc., and they can be helpful, but I wouldn't say they're as good as you being able to manipulate exactly what you want with your clinical hands. So if it's at all feasible, I would train your receptionist to take the scan, because it's once they've sort of got used to how far back they've got to stand and how they sort of move from side to side to capture the impression of the foot, I would get them doing that, and then you manipulating the foot, because at the end of the day, you're the podiatrist and you know what position you want the foot in. But that's just a suggestion. You might already be using this and be getting really good results. But if you are using it and you're not getting good results, then perhaps this is something to think about. Also, I would definitely practice on a fellow member of staff, or a guinea pig, not an actual guinea pig, but practice on somebody first, because although it's easy once you get used to it, as you can see from the previous slide, you can sort of mess up the scan a little bit. So, but with a little bit of practice, you can get some really, really great scans with this device. So neutral position. I couldn't really go through a presentation about casting without discussing the ever hotly debated topic of neutral position. So we could look into what is neutral and look at all the evidence, and can we measure neutral, and how do we palpate teleonavicular congruency? Is this really what Root says? Because this all comes back, a lot of this comes back to Root, and is it proved, is it disproved, what do we believe, does it actually work? Again, that's a whole different topic, and if you go on some of the podiatry forums, there's lots of arguments for and against neutral position and where it's come from, and is it old hat, and do we want neutral? But anyway, if we skip all that and think for the here and now, and the lab still needs a reference point, okay, and you still need a reference point. So while you could say that, you know, subtalar joint neutral or neutral position isn't brilliantly repeatable or evidence-based, until we've got something to replace it with, we still need that reference point. So I would avoid using the term subtalar joint neutral, and for the casting process, we'll just use the term foot neutral position. So what you want to be doing, and this is whether you're doing Plaster of Paris, whether you're doing frame impression boxes, or whether you're doing using scanning or the resin method, is the tail navicular. It needs to be maintained in a congruent position by palpation. So moving the foot from supination to pronation until you get that talar navicular congruency. And then the forefoot is fully pronated, so dorsiflexed, abducted and everted against the rear foot. So that is your foot neutral position. And if you've got your cast in this neutral position, basically this captures the following. So this is what is then transferred to the lab. So you've then got an accurate forefoot to rear foot position. It accurately shows the inclination angle of the calcaneus, and that's quite important when it comes to giving us reference points and marking where your navicular is. Because if you think about pronation and supination, everybody thinks about it in the frontal plane and the eversion and inversion of the angle and the bisection of the calcaneus as you look at the foot from behind. But supination and pronation is a triplanar movement, so it doesn't just occur in the frontal plane, it also occurs in the sagittal and the transverse planes as well. So as the foot supinates and pronates, if you look at the foot side on and you look in the sagittal plane, you'll see that inclination of the calcaneus, basically that angle goes up and down, so it drops up and down. So the more pronated, the more that angle drops. And the more supinated the foot, the higher the inclination of that calcaneus. But as I said, that will capture nicely in there if you've managed to get the foot neutral position. It also captures the plantar arch contours. It's unaffected soft tissue contours of the foot, and it captures the foot in an uncompensated position. So particularly if you've done this using one of the non-weight bearing methods, if you've done impression casting, then that's only weight bearing, so that is slightly different on there, even if you have put the foot into neutral, because you've got an element of weight bearing in there. First ray position. So anyone that's been casting for a long time will know that we used to be taught to plantar flex the first ray, because this was very important because of the windlass mechanism and so on and so forth. And there's lots of evidence that points towards the first MPJ's dorsiflexion. So if this is reduced, or dorsiflexion is reduced when plantar flexion is limited, and you get things like functional hallux limitus. Limitus, is that a word? Limiti, functional hallux limitus. So we know there's lots of stuff in the research and the sort of the evidence base about that. But the case of whether we incorporate that into a cast or not, again, I think depends entirely on your patient. So we can address things like functional hallux limitus with things like a first ray or a first met cutout or kinetic wedges or met domes or all sorts of other things on a prescription. But then you could argue that if you just plantar flex the first ray when we casted, then you wouldn't necessarily need to put all those things on an orthoses. There's also the argument, if you don't plantar flex the first ray position, does it mean that the resultant orthoses, so the orthotic which you get back, will that then hold the first MPJ in a dorsiflex position? Because if you're making a polyprop device, if you've got a hard piece of plastic holding that first ray in a dorsiflex position, then you're creating a functional hallux limitus that you perhaps didn't have there before. So there's those sort of things to consider. But then also, if you are plantar flexing the first ray, then you're engaging the windlass. So then will you be lowering the arch? Will you be putting a plantar fascial groove in there? What effect is that having? So again, it just comes back to what you want to achieve. Also, if they haven't got much, if your patient's an elderly patient that doesn't have any range of motion in the first MPJ anyway, do you want to be trying to encourage that? Do you want to be encouraging that, or do you want to be limiting it? So I wouldn't necessarily plantar flex the first ray of every single patient I casted, but I might with some patients, but I might not with others, and that'd be for various different reasons. And it all comes down to what I'm trying to achieve, and what range of motion that patient has, and what I'm addressing, and what their diagnosis is. So sometimes I'd do it, sometimes I wouldn't. The thing is as well, could you actually do this with a semi-weight bearing cast? So if I did want to plantar flex the first, is it as easy to do if I've got a semi-weight bearing casting method? Which brings us nicely on to foam impression boxes. Now, these aren't the most popular form of taking a foot impression at the moment. They're certainly a very close second after Plaster of Paris. and we've all probably seen these or had a play about with them. It's a sort of an oasis foam, and then you push the foot into it to get a foot impression. So lots of pros and cons with this again. So it's quick, simple and clean. You can capture semi-weight bearing, which might be preferable if you're doing more feet for elderly patients or sort of total contact insoles, that kind of thing. It does capture soft tissue spread, which is quite handy. So rather than on a non-weight bearing cast, you have to consider how much soft tissue spread or fat pad spread you're going to get when the patient goes from non-weight bearing to weight bearing. This already captures it, so that might be preferable, maybe if you've got a patient with edema or something like that. It's easier for elderly patients who have problems laying on their front or laying on their back. It's also for easier for younger children as well, because it's quick and easy. The disadvantages are if you've got someone with very flexible feet, and if you've ever tried to put your foot in one of these, you'll feel the upward force of the foam. So what could happen if you've got someone with a particularly flexible foot is it distorts, and it can give you things like it can create a forefoot varus within that cast, which you wouldn't normally see, and that's caused by the sort of the upwards sort of force or upwards pressure of the foam as you're trying to push the foot in. So you may not get an accurate representation of what that foot's doing, but again, you could check that afterwards. It doesn't capture the sides well. So if you have got someone with a sort of anatomical variances on the sides of the foot, it won't capture that because it doesn't mould around, because you're literally pushing the foot in and taking it back out again. Still needs to be taken accurately, and I'll show you a picture in a minute of one of many bad casts which get sent into the lab. There are some issues with referencing the foot's position in space with this. And that's largely if you're pushing down too much on the forefoot or the rear foot, or you haven't got it exactly flat. It can be difficult for the evaluation team at the lab to script, and it can cause problems if you've got patients with things like osteoporosis, because when you stick your finger in the foam, it feels very easy to go in. When you've got the whole plantar surface of the foot, there's quite a force pushing up there. So if you've got someone with very fragile joints or issues or problems, then this isn't the best method to use for them. So there we go, there's another one. As a lab, we get a lot of issues with foam impression boxes, and this is just one. So never assume something is that quick and easy. And you can see here the foot's literally just been plonked in, and I don't quite know what on earth's gone on around the side, but I think this one actually got sent back. But we do get a lot of issues with quite bad foam impression box casts sent in, where people or clinicians just haven't thought about that communication process, basically. So a quick guide, and as I say, this is a guide, it's not set in stone, but ideally you want to hold the foot in the neutral position as we discussed, by supporting the talus, and then use your free hand to press down on the patient's knee, which you can see in the picture there. So that just helps push the foot into the foam. And then simultaneously apply pressure to the lateral border of their foot with your other hand. So you're still holding the foot in neutral, but using the lateral border of your hand to help push the lateral border of their foot in. And then press the toes into the foam and slightly dorsiflex the hallux. But what you want to make sure is that the hip position and the knee are at about 90 degrees, and the ankle as well. So you're not getting the heel pushed in further or the forefoot pushed in further, or you're not pronating or supinating. You're getting a nice neutral position there. Now, one of the things we don't recommend is the walk-through technique. No, this is easier to take in a sense, because the patient's whole body weight is then going through the foam impression rather. But the thought behind it is you put the box on the ground, you space it out accurately, and then the patient walks along and walks through the foam impression, so you get a sort of fully weight bearing sort of loaded foot impression. Now, a couple of people do use this and get very good results, and that's great, but generally speaking, the people that try it and don't necessarily understand what they're doing with it don't get particularly good results, and that's because as you get through mid stance and the foot has excessively, or it's pronated somewhat anyway, so then you end up getting a finished device which can sometimes be too long or too wide, because you're getting a pronated position in there as well, and you haven't necessarily scripted for that or explained it. We also don't recommend fully weight bearing impressions either. So if you do that and you get on with them at the moment and everything's fine, it might be worth giving the lab a ring and having a chat with them. But if you're just starting with this, or someone suggested this technique, we wouldn't necessarily recommend it, and it's, as I say, for those reasons, that they don't create brilliant devices. So on to references. So always remember your references, and this is a bit of a new thing we've been pushing. Some people do this as standard, the vast majority of people don't. I've always marked the bisection of the calcaneus or posterior heel, but I've never really thought about marking the first, the fifth, and the navicular. And actually this is quite crucial to your scripting. So always consider the foot that you've captured versus the actual foot, and versus the script or the prescription variables that you've got. So has your foot impression, does it match the actual foot that you're looking at in front of you? And then does it match with what you've prescribed on a prescription form? And those three things are all going to tie up, really. So you can put as many references on there as you like. If you've got somebody that's coming with something weird and wonderful, then mark that as well. If they've got lesions on their foot or any osseous abnormalities or anything quirky, mark that. But generally speaking, these are what we would like to see on every single cast. So the first met, the fifth met, the bisection of the calcaneus at the back, the navicular position, and remember I said earlier about the inclination of the calcaneus. This is where the navicular position is important, because the highest point of your arch wants to be under the navicular, not under the actual arch. Because if it's under the navicular, it's helping to control that pronation supination movement in the sagittal plane, whereas if it's underneath the arch, all it's doing is pushing up under the mid-tarsal area. But then if you want any padding, specifically net pads or things like that, mark that on there as well if you've requested it. So draw that on and picture where you want it. Send an accompanying template if necessary to mark on weight-bearing lesions, and always include your shoe size on your prescription form. So any information you can think of that you want to add, send it along with the cast. It's always better to get too much information that we don't need than not enough information and then having to guess it. Now, reference points aren't always the be-all and end-all of everything. You've got to think about how accurate you are. This can be different on different people's feet. I mean, if you get a teenage boy in who's really, really skinny and you can see just about every piece of anatomy through his surface anatomy, then that's great, because it's really easy to pinpoint the navicular and various other structures. But if you've got someone that comes in and they've got a lot of edema or they're overweight, sometimes it's harder to pinpoint some of those structures. So knowing your anatomy is crucial on there. But then sometimes you get things like skin movement. So if you've bisected the calcaneus and then you've got skin movement on there, that can affect it. If you have got something else, if you've marked the first met but it's about 5 mils out, that depends on how big the foot is to what difference that will make. But if it's a small foot, 5 mils is a lot. If you work in a practice with different clinicians, what do you like between clinicians, marking reference points? So it's not a perfect way of doing things, but the more information you give, the better. And what you have to think is that if you don't mark these things on here, then the lab has to make an educated guess. So even if you're guessing as well, the likelihood is that you'll have a better guess because you've got the patient there in front of you, whereas the lab or the people in the lab haven't. So it's better coming from you. You see on the picture there as well, always send, if you can, send pictures as well. That's always great. And the chap here has written UK size 4 on there, and he's also used a 20p piece as a reference point to show sort of sizings and markings. I think he's also written the width of the heel on there as well. So something like that's great. The more information, the better. But as I say, do put these reference points on, whether you're doing Plaster of Paris, whether you're doing scanning, whether you're doing foam impression boxes, or whether you're doing the slipper socks. Always add this if you can. And then when you've taken your cast, you then want to be going through this checklist. So hallux slightly dorsiflexed, and you want to see a concave first metatarsal head impression. That sort of ties in with dorsiflexing the hallux slightly. The arch shape wants to represent the patient's foot in neutral position. So when you're checking your cast, again, whatever method you've chosen to use, have that up against the patient's foot and make sure they pretty much look like they're mirroring the same. Proximal phalanx, the fifth, should be parallel to the metatarsal shaft. You want an accurate forefoot to rear foot relationship, so make sure you haven't captured a supinatus, and this is particularly Particularly important if you're doing a foam impression box, because you could get the pushing up, which could create a supinatus that you didn't have before, or that you can't see or isn't evident on the patient's foot. If you use foam impression boxes and you have issues at the moment with your devices rocking, then this is something you probably want to have look a little bit closer to see if you're capturing an unwanted supinatus in there. The border or the lateral border of your cast wants to be straight, particularly underneath the calcaneal keyboard area. So if it's a bit convex, you may have supinated the foot a bit, or if it's a little bit more concave, you might have pronated the foot a bit. So no banana-shaped cast sent in unless the patient does have indeed a banana-shaped foot. The apex of the lateral arch wants to be under the calcaneal cuboid joint. Make sure your heel or your metatarsals haven't bottomed out, and that's particularly if you're using a semi-weight bearing method, so either scanning or foam impression. You don't want any bottoming out or flattening on those met heads or underneath the heel. Clearly mark the bisection of the calcaneus first, fifth metatarsal heads, and clearly mark your navicular position. Also, if you're doing scans or plaster of Paris, you can look for the skin sort of impression and the lines that you get on the skin as well. And if you transfer those two onto the cast, you know you've got a nice close cast. So no sort of lumps and bumps and bubbles on there, if you can help it. Right. Quite good, I didn't realise I've been talking for that long. So sort of bring it all to a conclusion. As I say, I haven't given you an exact black and white list of exactly how to take in a cast, and you only use this method, and completely black and white. All comes down to your patient. The main thing which I hope you've gotten from this presentation is understanding the principles of taking a cast and getting a good 3D impression. So as I said before, if you want to send in a daub of Play-Doh with a foot impression in it, if it's got all the information and it communicates what you want well to the lab, then all well and good. Although I say that as a joke, I wouldn't start messing about and trying the other methods other than the 4 we've discussed. The other thing is, and this is where it's really easy to forget, and I've been on various sort of casting courses and parts of sort of seminars and things where we look at the casting and we look at the methods and we discuss everything around it, but then you sort of forget about your patient almost. And what sort of patients are you seeing? Are you just seeing fit mobile athletes where you want these sort of fully functional orthoses that you can manipulate their foot into whatever position that you want to for the activity or sport that they're doing? Or are you seeing at-risk patients with limited range of motion? Those patients that can't lay on their front, they can't lie on their tummy. It's all very well saying plaster of Paris, non-weight bearing is better. But if you can't get the patient in that position, then you can't use those methods. And also with the neutral position, if you can't even manipulate the foot into a neutral position or take out the supinatus, or maybe they've got a fixed forefoot varus or osseous changes within that foot, then you're not going to get your perfect looking cast that will be described in sort of some of your checklists. So, but then you also wouldn't be making probably a rigid, fully functional orthotic for them either. You'd probably be making something out of EVA or something softer or something more designed towards the at-risk foot. So what sort of patients are you seeing? They're quite two extremes there. Most people are seeing something somewhere in between. Generally speaking, or probably always speaking, the better the foot impression, the more accurate your orthosis will be. So think back to the communication. The better you can communicate something across to somebody the other side of the country in a lab that you've never spoken to make your device, the better communication and the more information you can give, the better and more accurate your finished device will be. And if you are having problems and your orthoses aren't coming back as you expect, it's very, very easy to think it's always the lab's fault, and sometimes it is. But is it the fault of the lab, or is it a fault in the communication? And that's not to say it's the clinician's fault in the communication. It might be how the technicians or the clinicians in the lab read that communication, but somewhere along the line that communication has failed. So a little bit like our video that we watched earlier on, where the guy at the beginning does a demonstration, and 20 people down the line the demonstration's completely changed. It's not to say it's the fault of the first person doing the showing or the fault of the last person receiving what's been shown, but somewhere along that communication line something's altered or something's broken down. And more often than not, when there's an issue with devices, it's a breakdown in that communication along the way somewhere. So more information you can send, the better. So See, there's my dismal reference list, all of 2.